نسيت اقول ان انا بسعد طبعا لما مع كوكبه من الدكتوره نهى، الدكتوره نيلي، والدكتوره رنا. طبعا اتس بليجر ان انا ابقى معاكم صحيح في ذيس انتجريتد سيشن. واحنا طبعا وجود الجراح وسطنا دي مهمه جدا. اتفضل.
السلام عليكم. اولا طبعا انا سعيد بوجودي في داي ايجيبت السنه دي اول مره. بتشرف طبعا بوجودي مع استاذ دكتور سمير اسعد استاذنا جميعا، والدكتوره نيلي شمس بشكرها لدعوتي ليها يعني في المؤتمر. دكتوره نهى جابر استاذه السكر، ودكتوره رنا اصدقائي الاعزاء. My talk is about a very challenging topic, post-bariatric surgery. Any patient subjected to bariatric surgery is expected for his goal to reach the ideal goal or to have weight loss. What if the patient have weight gain or failure of weight loss? It is a struggling issue, and patients however, they passed without any complication. They didn't reach their goal. So how can we deal with this problem? I will talk about the surgical issues, the causes, and if there is any surgical solution after bariatric surgery. All of us know that the bariatric surgery can achieve weight loss. Definitely, it treats the obesity and it treats the comorbidity. Despite effective weight loss, some patients do not achieve the target goals, and others regain a specific portion of their weights at a long-term follow-up. Weight regain is have a range of the undesirable medical and psychological impact for the patient. As a surgeon, I have to inform you, I think all of you know most of the types of bariatric surgery, but the nutritionist should know well all types of bariatric surgery, the old one and the new one, because there is innovations. Here we have one, the old one, the BBG, vertical banded gastroplasty, the lap band, here the adjustable gastric band, and the gastric plication. It is restricted procedure and now it is abandoned. The upper three one are the well-known and the recent one, the laparoscopic sleeve gastrectomy, and the Roux-en-Y gastric bypass and mini gastric bypass. Of course, there is another one which is a temporary procedure, which is endoscopic gastric balloon. It's out of the scope of the comparison with other procedure because it is a temporary procedure endoscopic. We cannot consider it as a bariatric surgery. Weight regain might occur after bariatric procedure to different extent at a variable time. The cause of weight regain, we can categorize it as a multifactorial, either a patient-related or procedure-related. However, weight regain might occur despite of the patient's stated adherence to all behavioral measure and absence of any surgical cause. This suggests that the preoperative and the postoperative demographic and physiological and metabolic features could play a role. From that point, we can go for that the multimodal management strategy should be included for this patient per se. As a definition for weight regain or insufficient weight loss. Which of which? Weight regain, if regain of weight after achievement of successful weight loss. The successful weight loss is defined as the percentage of excess weight loss above 50%. Insufficient weight loss, that the percentage of excess weight loss did not reach 50% at about a year and a half after bariatric surgery. A lot of definitions have been notified, either BMI reaching above 35 after successful weight loss, or BMI, increase in the BMI more than 5 kilograms per square meter above the normal weight, or the increase in the excess weight loss above 25% regain to normal, increase of the weight 10 kilograms from normal, any weight regain after type 2 diabetes remission, or increase to 15% of total weight after normal. Most of the bariatric surgery have percentage of weight regain, but a different percentage or different at different time. The most common type of bariatric surgery to have weight regain is the lap band. Then the lesser of weight regain is the Roux-en-Y gastric bypass. Also, the second one is a mini gastric bypass. As I've said, that there are two factors related to the weight regain. Either patient factor, could be hormonal or maladaptive lifestyle behavior like dietary non-compliance, physical inactivity, lack of follow-up support, psychological causes, or maladaptive eating. And my issue I will talk about it is a surgical cause, either enlargement of the gastric pouch created, or gastrogastric fistula, or a wrong technique. I mean, if the patient did the bariatric surgery, should not be concluded that this is the right technique. It could be a wrong technique, or it could be not done well. I'll talk about every technique separately. The lap band, it is an old procedure. It is an adjustable gastric band. The patient should follow the surgeon to adjust this band, either to inflate the band or to deflate the band according to the circumstances. The success rate related to the follow-up with the patient with the surgeon by saline adjustment. Weight regain related to the pouch distension, which is managed either conservatively or by reinforcement of the portion size. Most of the cases of lap band can go to complications, so the band can be removed, and this may be the cause of weight regain. We found that 12% of patients with early band removal, they maintain their current weight. With a long-term follow-up with the patient, band removal is high, either because of reflux, either because of band complication. So we conclude that we expected that this patient can regain their weight. And after a long time, these patients of band were subjected to another procedure, about 30% of cases. As we can see here, the band, this is the normal band, this one. But on the left side of the screen, we can have pouch distension, either anterior, posterior, diffuse, or band complication like band slippage. If the band slipped, the pouch will be bigger, so the patient can have a big amount of food, and we can conclude that there is a band failure. What are the kind of surgery that can be done for the patient with band complication? Either can be converted into sleeve gastrectomy, which is a restrictive procedure also, or it can be subjected to bypass, either mini or Roux-en-Y gastric bypass. For the sleeve gastrectomy, why the sleeve gastrectomy may fail? If the pouch dilate. Over time, the patient with sleeve gastrectomy, their pouch may dilate, so the restrictive pattern will be lost, so the increased gastric capacity, the patient can eat more, and this will lead to weight regain. How can we know this? As a surgeon, we can know this by what is called CT volumetry. In the old days, we did for the patient barium meal or gastrographene meal. Now, the CT reconstruction we can see the stomach, and it can fashion the stomach. We can see which part of the stomach is dilated. We'll see the picture now. Several theory for the weight regain after sleeve gastrectomy, either physiological dilatation of the remnant stomach volume or incomplete removal, which is wrong technique, with complete removal of mainly the stomach fundus. So we can note that the success of the procedure depends on the learning curve or the technique of the sleeve by itself. So what is the ideal sleeve? The ideal sleeve is to pass, to calibrate the stomach by 40 Bouget, 40 French, and to leave 1 centimeter for the gastroesophageal junction, and to leave 3 centimeter from the incisura angularis, and to leave 5 centimeter from the pylorus. It is not a success to narrow the stomach, because we can be faced with a patient with twist of the pouch or narrowing of the pouch, and this will lead to gastric outlet obstruction, and the patient can go into nutritional problem. These are the picture of pouch dilatation of the stomach, either antral dilatation or fundus dilatation or fusiform, all the sleeve could be dilated. And this, how can we see the stomach dilated by CT volumetry? The CT reconstruction can see either the stomach is fusiform dilated or the fundus dilated, which is the commonest cause of sleeve failure is a fundus dilatation. Also by 3D and image colored, we can see the first picture with fusiform dilatation. The second picture is hourglass stomach. It's narrowing in the middle and the dilatation above and lower. And the third one is a fusiform dilatation. Going through the third technique is a Roux-en-Y gastric bypass. Roux-en-Y gastric bypass produce restriction by restriction of the food intake and malabsorption. Weight regain can occur after Roux-en-Y gastric bypass either by dilatation of the pouch of the stomach, which is with a 15 millimeter pouch, or the gastrojejunum itself if it is created wide, so the stoma could be wide. This leads to loss of satiety, increase of food intake, and can occur also if there is fistula that occur between the pouch and the stomach. How can we diagnose this? You can diagnose this also by CT volumetry, by upper endoscopy, by barium meal, and if the stoma diameter is above 2 centimeter, most of the cases have a weight regain. How can we solve this? By reduction of the anastomotic size, either endoscopic or by surgery, or we can refashion the pouch surgically and we can refashion the limbs. This is the Roux-en-Y gastric bypass. There is a small stomach pouch, about 15 centimeter, and there is long limb, which is alimentary limb, passing the food through it, and there is a piliopancreatic limb about 150 cc. There is a special length of this length that should be created, and if we change this length, the patient outcome could be changed. Usually, there is the pouch. Usually, the pouch should be fashioned about 15 centimeter, and the anastomosis should be about 2 centimeter between the stomach and the intestine. The gastrojejunostomy, we call it the stoma, and there should not be a blind limb. This blind limb can lead to what is called candy cane, which is like a big stomach. The alimentary limb should be about at least 1.5 meter, and the biliopancreatic limb should be at least 60 centimeter. If we elongate the biliopancreatic limb, there will be more weight loss on the extent of the nutritional loss. If we elongate the alimentary limb, there will be more malabsorption. So the length of these limbs affect either the nutritional effect or the weight loss. By conclusion, we cannot leave less than 2 meter from the ileocecal junction. Otherwise, the patient will have short bowel syndrome and can be subjected to nutritional problem. How can we deal with the stomach dilatation? With the pouch dilatation, either endoscopically, but with what is called endostitch, or to narrow either the stomach or to narrow the pouch, or to manage it through surgical interference. So the revision of the bariatric surgery can be between the restrictive procedure into the malabsorptive procedure, or from the malabsorptive procedure into refashioning by elongating the limbs of the bariatric, of the biliopancreatic or the alimentary limb.
أذنك بس نزود 5 دقايق لدكتور شرعان.
Two other procedures that you should know about them, what is called SADI and SASI procedure. These are two combination between sleeve gastrectomy and bypass. The SASI operation, it is a single anastomosis sleeve ileal bypass. We do the sleeve gastrectomy, then we anastomose the stomach with gastric bypass. The SADI, it is the same, but we anastomose it with the duodenum, and we leave only 2 to 3 meters from the ileocecal junction. These are very aggressive bariatric procedures. I do not like them because nutritional problems can happen with them. For the outcome of the surgical revision, if the patient is subjected to surgical revision after bariatric surgery, most of the causes of this revision due to weight regain and insufficient weight loss. From band to sleeve or bypass, the percentage of excess weight loss can reach from 20 to 30%. From sleeve to Roux-en-Y gastric bypass, the percentage of excess weight loss can reach about 30% in 2 years. We can notice that these percentages are not too high like the primary bariatric procedure. For the revision of Roux-en-Y gastric bypass, distalization about 50% can lead to more weight loss, pouch refashioning 14%, narrowing 25%, and banded bypass 13%. My take-home message that the bariatric surgery remained effective and durable for treating obesity and its comorbidity. Enhanced knowledge of the hormonal and psychological and behavior and surgical cause of weight regain could provide an evidence-based management strategy, preoperative assessment of patient, and better selection for patients with bariatric surgery could prevent insufficient weight loss. Better understanding of the effectiveness and safety of all the procedure for weight loss can assist in selection of the right way to deal with the patient with weight regain post-bariatric surgery. And the most important is the multidisciplinary team management plan should be tailored for the patient, each patient per se, in order to achieve a resolution of weight regain post-bariatric surgery. Thank you so much.